as a payer, there's no shortage of technologies or devices or therapies that people are asking to be paid for. How do you handle that? How do you make the decisions regarding what makes sense, from a payment perspective, given all these various factors?
Sure. There's a number of things that are looked at. Clearly, data that has been published and well-reviewed is key, is the data that shows that whether it's the technology, the tool, whatever, actually adds, that it does what it says it does and that it adds benefit, that there's a positive outcome. Is there acceptance that this tool or technology is going to help our member in some way, preferably in terms of either driving down cost, improving the health, improving whether it's A1C, or just being more adherent and attentive to their disease state. What specialty societies say carry weight. And then also, since each technology in a way is unique in and of itself, so unlike a medication, that there's a chemical formula, and if you make metformin, it better be metformin regardless of which factory is making it. But from a technology platform, there are little tweaks and differences between them, and those little tweaks and differences can result in either success or failure. And so each one has to be reviewed on its own. And one of the things you have to look at is what are the unique properties to the tool or technology that yields the outcome, and does the next device or tool carry the same properties with it?
And I think, one of the other challenges for devices, that pathway of sort of making iterative changes makes sense, and each thing is regulated and reviewed. But, in sort of these digital platforms, often, first of all, there are very few studies with them, but when they are done, usually the process of development is so rapid that whatever they tested 2 years ago, they've got a completely different version 5.0. And so, our clinical trial system can't do the studies fast enough for the iterative changes in digital technology.
Right. No, that's absolutely true. And oftentimes those trials will then have a population of folks who, of course, are engaged. They wanted to be in the trial, they wanted to use the technology, and are they doing better than their peers because of the technology, or are they doing better because those are the folks who just do better, and they would do better even if they didn't have good technology? They would riddle it out even in the absence of technology. It is one place where big data, data that's collected such as by a payer, looking at outcomes can really be mined and understood of, can we show outcomes in ways and do studies in ways that really aren't practical, as you say, in the traditional blinded, controlled study system.